So now we'll be talking about the epidemiology and biostat. So the case series is described as several individuals, patients with the same diagnosis, treatment or outcome. So description of the clinical findings, symptoms has no comparison group and thus cannot show the risk factor associated with disease. Now we have cross-sectional study. Frequency of the disease and frequency of the risk-related factors are assessed in the present, asking what is happening. So cross-sectional is like frequency of the disease and frequency of risk factor are accessed, okay, in the present. So it cross-sectional study determines the prevalence and can show risk factor associated with the disease but does not establish the causality. Case control, which is retrospective, compare a group of people with disease to a group without disease. So odds ratio. So looks what happened, okay, and cohort study compares a group with the given exposure or risk factor to a group with such exposure to look at, or to see if exposure or risk factor is associated with the later development of disease. Can be prospective or retrospective, and we calculate the relative risk. So we have twins concordance study, compare the frequency with which both monozygotic twins versus both dizygotic twins develop the same disease. So measure the heritability and influence of environmental factors. We have adaptation study, compare sibling based by biological versus adoptive parents, measure heritability and influence of environmental factors. We have ecological study, compare frequency of disease and frequency of risk factor across population, measures population data not necessarily applicable to individuals, used to monitor population health. COPD prevalence was high in more polluted cities. So we have the clinical trial. So experiment studying involves humans, compares the therapeutic benefit of greater than 2 or equal treatment or of treatment and placebo. So study quality improves when study is randomized, controlled or double blinded. Neither patient nor researchers know whether the patient is in the treatment or control group. 3 blind refers to the additional blind of the research analyzing the data. So next we have the crossover study, compares the effect of a series greater than 2 treatment or a particular order in which the participant received treatment is randomized. Washout rate occurs between treatments. So allow the participants to solve as own control. Intention to treat analysis, all patients are analyzed according to their origin. Randomly assigned treatment, no patients are excluded. Attempt to avoid misleading bias from patients dropping out. Per protocol analysis, only patients who complete the study per protocol are included in analysis. Patients who fail to complete treatment as originally random assigned are excluded. Risk of bias from non-random compliances. We have the phase 0, very small of the either healthy volunteers or patients with disease of interest. Initially pharmacokinetics and pharmacodynamics assessment. Use less than 1% of therapeutic dose. No safety or toxicity assessment. So the next is phase 1, which is small number of either healthy or volunteers or patients with disease of interest, more than phase 0. Is it safe? Access, safety, toxicity, dose, pharmacokinetics and pharmacokinetics. Phase 2 is moderate number of patients with disease of interest. Does it work? Access, treatment efficacy and adverse effects. We have phase 3, large number of patients with disease of interest, randomly assigned either to the treatment or investigation or to the standard of care. Is it good or better? Compares the new treatment to the current standard of care. Improvement. We have phase 4, post marketing surveillance of patients after treatment is approved. So can it stay on the market? So we have a Bradford Hills criteria, a group of principles that provides limited support for establishing evidence of causal relationship between presumed cause and effect. So we have strength, that is association does not imply causation, but the stronger the association, the more evidence for causality. We have consistency, that is repeated observation of the finding in multiple distinct samples. Specificity, the more specific the presumed data is to the effect and the stronger the evidence for causation. Temporality, the presumed cause precedes the effect by an expected amount of time. And biological gradients, that is effects observed with greater exposure to the presumed cause, that is dose response relationship. We have plausibility, the conceivable mechanism exists by which the cause may lead to the effect. We have coherence, the presumed cause and the effect do not conflict with the existing scientific consensus. We have experiment, empirical evidence supporting the presumed cause and effects, And we have analogy, the presumed cause and the effect are comparable to a similar established cause and effects. So the next will be talking about the quantitative risk factors, which will be disease outcome and events or exposure. So disease is plus minus and exposure is plus minus. So A is ABCD we have. So we have the odds ratio. So in the odds ratio, so we are having the odds ratio. So typically used in a case control study, responds the odds of exposure among the cases versus odds of non-exposure among controls. So OR equals to 1 is odds of exposure are equal in case and control. OR greater than 1 equals to odds of exposure are greater in cases. Okay, so OR ratio is AD by PC. Okay, so you need to remember the disease positive in both is A and the disease negative but exposure positive is B. Okay, that's it you need to know. So the next is relative risk, typically in cohort studies. So the formula for relative risk is R equals to A divided by A plus B divided by C divided by C plus D. Okay. So we will be talking about the relative risk reduction, that is 1 minus relative risk. So we have attributable risk and absolute risk reduction, which is simply the difference. Attributable risk is A divided by A plus B minus C divided by C plus D. In percentage, we can convert AR percentage is equals to RR minus 1 divided by RR into 100. So absolute risk reduction is C divided by C plus D minus A divided by A plus B. So number needed to treat is NNT is equals to 1 by ARR. Okay, and number needed to harm is 1 divided by AR. So number needed to treat is treat as a there is 1 divided by AR. Number needed to harm is 1 divided by AR. So case fatality rate is case fatality percent equals to death by case into 100. So we have the mortality rate. So now the death in general population due to specific cause within a population over a period of time, typically scaled to death per 1000 per year. So mortality rate is number of death in a general population due to specific cause with population over a period of time, typically scaled to death per 100. So attack rate is simply, so if 80 people in a town of 10,000 die over 2 years, mortality rate is 4 per 1000. Okay, 4 per 1000 per year. Okay, so attack rate is simply proportion of exposed people who becomes ill. So if 80 people in a town are exposed and 60 becomes ill, so attack rate is 70%. Is simply people who are become attack rate is simply people who became ill divided by total people exposed. So likelihood ratio is simply sensitivity divided by 1 minus specificity, or true positive rate divided by false positive rate. Whereas likelihood negative ratio is 1 minus sensitivity divided by specificity is equals to false negative rate by true negative rate. Okay, so LR positive greater than 10 in 10 indicates a highly specific test, and LR minus less than 1 equals to indicates a highly sensitive test. Okay, so evaluation of diagnostic test, we have the disease and the test. That was the disease and exposure. Similarly, now we'll have disease and the test. So true positive and false positive would be in the first row, and false negative and true negative. Okay, last time I will hear you. I know that true and false will be like cross. True, true, false, false would be cross. Okay, and in the first line will all be true positive by false positive, and true positive, false negative, true negative. So similarly, sensitivity is equals to true positive divided by true positive plus false negative. Similarly, specificity equals to true negative divided by true negative plus false positive. Similarly, the positive predictive value is equals to true positive divided by true positive plus false positive. Similarly, the negative predictive value is true negative divided by true negative plus false negative. Very, very high yield. Okay, so sensitivity is probability of all people who with disease who test positive, or the ability of test to correct identify those with the disease. Is sensitivity value approaching 100 is desirable for ruling out disease and negates a low false negative rate. So negative rules out the disease, and high sensitivity used for screening. So sensitivity is used for high sensitivity used for screening. Similarly, specificity is proportion of the people without disease who test negative. Okay, without disease who test negative. Okay, so is simply 1 specificity equals to 1 minus false positive rate. Okay, So spin is high specificity when positive rules out in disease. Okay, so highly sensitivity when negative rule out the disease, and specificity is when positive rules in the disease. High specificity means when positive rules in the disease. Okay, high specificity means when positive rules in the disease, whereas high sensitivity means when negative rule out the disease. Very very high yield. Okay, so we have the positive predictive value, probability that a person who has a positive test results actually has the disease. Okay, so PPV varies directly with the pre-test probability baseline, such as prevalence of the disease. High test probability equals to high PPV. So negative predictive value is probability that the people with a negative test actually does not have the disease. Okay, so NPV varies inversely with prevalence. So PPV varies, okay, it is directly to prevalence of a disease, whereas NPV varies inversely with prevalence of test probability. Okay, so we'll be talking about the disease present, that is true positive, and true negative would be like far of it. Okay, false, sorry, true positive and false negative would be far. Similarly, true negative and false positive would be far. So like lowering the cutoff value means lowering the cutoff value, we increases the false positive and decreases the false negative. Okay, lowering the value means we are increasing the false positive, no, and decreasing the false negative. Similarly, lowering मा चाहिँ के हुन्छ भने लोअरिङ द भ्यालु गऱ्यो भने सेन्सिटिभिटी बढ्छ, स्पेसिसिभिटी घट्छ, अनि सेन्सिटिभिटी बढ्यो भने पोजिटिभ प्रेडिक्टिभ भ्यालु चाहिँ घट्छ, स्पेसिसिभिटी घट्यो भने चाहिँ नेगेटिभ प्रेडिक्टिभ भ्यालु चाहिँ बढ्छ. ओके, भेरी भेरी हाई यिल्ड. So similarly, like raising the cutoff value when you do, so it raises the cutoff value, increases fun. Okay, you need to remember this. Increasing the cutoff value, when you increase the value, you will have fun. So false negative would be increasing, decreasing the false negative, and similarly we will have the increase in specificity, and there will be increase in positive predictive value. Okay, and similar decrease in sensitivity and decrease in negative predictive value. So receiving receivers operating. So एउटा कुरा मात्रै याद राख्ने, लोअरिङ द कटअफ भ्यालु भयो भने फल्स पोजिटिभ बढ्छ, लोअरिङ द कटअफ भ्यालु भयो भने बढ्ने कुराहरू के हुन्छ भन्दाखेरि फल्स पोजिटिभ बढ्छ, सेन्सिटिभिटी बढ्छ, अनि नेगेटिभ प्रेडिक्टिभ भ्यालु बढ्छ. तर हामीले जब रेजिङ द कटअफ भ्यालु गर्छौँ भने रेज गरेर छौँ, त्यही भएर चाहिँ फल्स नेगेटिभ बढ्छ, स्पेसिसिटी बढ्छ र पिपिबी बढ्छ. भनेपछि हाम्रो राइट ह्यान्डमा सम्झौँ, राइट ह्यान्डमा हामीले रेज गरिरहेछौँ, लेफ्ट ह्यान्डमा हामीले लोअरिङ गरिरहेछौँ. राइट ह्यान्डमा हामीले जब रेज द कटअफ भ्यालु गर्छौँ भने हाम्रो राइट ह्यान्डमा के हुन्छ भने फल्स नेगेटिभ बढ्छ, स्पेसिसिटी बढ्छ र पोजिटिभ प्रेडिक्टिभ भ्यालु बढ्छ. तर लोअरिङ द कटअफ भ्यालु लेफ्ट ह्यान्डमा गऱ्यौँ भने हाम्रो फल्स पोजिटिभ बढ्छ. सो मेरो लेफ्ट ह्यान्डसँग पोजिटिभ हुन्छ, फल्स पोजिटिभ बढ्छ, सेन्सिटिभिटी बढ्छ र नेगेटिभ प्रेडिक्टिभ भ्यालु बढ्छ. ओके, भेरी गुड. So now receiving operator characteristic of ROC curve demonstrate how well a diagnostic test can distinguish between two groups, healthy versus disease. Plot this true positive rate sensitivity against the false positive rate 1 minus specificity. The better performing test will actually have higher under the area curve with the curve closer to the upper quadrant. So precision and means the reliability, the consistency and the productivity of our test, the absence of random variation in a test. Okay, so increased precision decreases the standard deviation, whereas increased precision increases the statistical power. Okay, so increased precision would decrease the standard deviation, but increase the statistical power 1 minus beta. Okay, similarly the accuracy and validity, the closeness of a test results to the true values, that the absence of systemic error or bias in a test. Systemic error decreases the accuracy in a test. So how to remember is प्रिसिजन भनेको चाहिँ हाम्रो सँगै हुनु, प्रिथी, पी फर प्रिसिजन, पी फर प्रिथी. सो प्रिथीहरू सँगै भयो भने चाहिँ हैन, द्याट इज वुड बी प्रिसाइज, बट एक्युरेसी इज नट प्रिथी. सो एक्युरेसी भनेको चाहिँ सेन्टरमा हुनुपर्छ. ACC, C भनेको चाहिँ सेन्टर। सो सेन्टरमा भयो भने चाहिँ हाम्रो एक्युरेट हुन्छ र हाम्रो सँगै भयो भने चाहिँ प्रिसाइज हुन्छ। सिमिलरली प्रिसाइज भनेको चाहिँ टाढा लो छ अथवा टाढा टाढा छ, तर यसमा प्रिसाइज छ तर यसमा चाहिँ छैन। सो इन्सिडेन्स भर्सेस इन्सिडेन्स मिन्स टोटल नम्बर अफ न्यू केस बाई total number of people at risk. Okay, so prevalence is people of existing case by total number of people in population. So prevalence divided by 1 minus prevalence is equals to incidence rate times average duration of the disease. So prevalence is equals to incidence for short duration disease, and prevalence is greater than incidence for chronic disease such as large disease exists. Okay, diabetes. Increased prevalence increases the uh, positive predictive value and decreases the negative predictive value. So increased survival time, no change, there is only increase in prevalence. Increased mortality, there is decreasing in the prevalence, and the faster recovery time, we have decreased prevalence. These things, increased survival time, mortality and fast recovery does not affect the incidence, whereas the existing vaccine administration decreases both the incidence and prevalence, as well as with the decreasing the risk factors, and increased diagnostic sensitivity increases the incidence and increases the prevalence. Okay, so next we'll be talking about the biases. Okay, so selection bias, so non-random sampling of treatment allocation of subjects such that a study population is not represented of a target population. So most commonly a sample bias. So in the selection bias, we have the Burke-Son bias, that is case or control selected from hospitals. Bedside bias are less healthy and have different exposure. Whereas attrition bias is participants lost to follow up after a different prognosis than those of complete study. So to decrease the selection bias, we must randomly select the population. Okay, randomly creates group with similar distributors of known and unknown variables, ensures the choice of the right comparison preference group. So now this was the recruitment participants. Now while performing the study, we can have bias like recall bias, measurement bias, procedure bias, observational expectancy bias. So recall bias is simply awareness of disorder alters the recall of the subject. Order common in retrospective study. Patients with the disease recall exposure after learning of similar cases. So studies to reduce is decrease time from exposure to follow. Okay, so recall bias जति चाँडै गर्ने त्यति राम्रो. Measurement bias, information is gathered into a systemic distorted manner using a faulty autonomic spigometry. We have the Hawthorne effect, that is participants change behavior upon awareness of being observed. Okay, so the strategies to reduce the measurement bias is standardized and precise measure tested method or data collection that has planned ahead of time. Use placebo group. Now we have the procedural bias. Subjects in different groups are not treated the same. Patients in the treatment group spend more time in high specialized hospital units. Okay, and next we have the observational expectancy bias. Researchers believe in the efficacy of a treatment change the outcome of the treatment. Okay, that is Pygmalion effect. Researchers believe in efficacy of a treatment change the outcome of the treatment, that is Pygmalion effect. An observer expected treatment group to show signs of recovery is more likely to document positive outcome. So we can decrease the procedural bias and observational expectancy bias by strategies to reduce this bias includes blinding, masking, and use of placebo reduces the influence of participants and researcher on procedure and interpretation of the outcome as neither are aware of group assignment. Okay. Now we have interpreting results. So the confounding bias, we have while interpreting results, we have three bias: confounding bias, lead time bias, and length time bias. So confounding bias means factor related to both exposure and outcome distorts effect of exposure on outcome. Okay, effect modification in which the exposure leads to different outcome in subgroup stratified by factor. So an uncontrolled study shows an association between the drinking coffee and lung cancer. However, people who drink coffee may smoke more, which could account for associations. So multiple repeated, how can we decrease the strategies to decrease the confounding biases? Multiple repeated studies, crossover studies, subjects as their own control, matching patients with similar characteristics in both the treatment and control group. Very high yield. How to decrease the confounding biases? Multiple repeated studies, crossover studies, and matching. Okay. So next is lead time bias. Early detection spread has increased survival, but the disease course not changed. Lead time bias, like breast cancer diagnosed early by mammography may appear to exaggerate survival time because the participants are known to have the cancer for long. So the how to decrease the lead time bias would be strategies to reduce is measurement back end survival, adjustment survival according to the severity of the disease at the time of diagnosis. So next we have lead time bias. So lead time bias means screening test detects disease with long latency period, with those with shorter latency period becomes symptomatic earlier. So a slowly progressive cancer is more likely detected by a screening test than a rapidly progressive cancer. A randomized controlled trial assigns subjects to the screening program or to no screening. Okay. So next we have the statistical distributions. So measurement of central tendency, mean is equals to sum of the value divided by total number of value. Median is equals to middle value of a listed data stored from least to greatest, and mode is the most common value. So mean is the most affected by outlier, the extreme value. Median is if there is an even number of value, the median will be average of the middle two values, and mode is the least affected by outliers. So most affected is mean, and the least affected by outlier is mode. Okay, so mode is the most affected. Mode is least affected, whereas most affected is mean. Okay, so standard deviation is how much variability exists in a set of value around the mean of this value. Okay, so standard variance is a square of the standard deviation, whereas standard error is simply standard deviation divided by root under n. Okay, so standard error is estimate of how much variability exists when a set of sample means around the true population mean. So next we have the normal distribution, Gaussian curve, also called the bell shape, mean equals to median equals to mode. Okay, in normal Gaussian curve only the mean is equals to median equals to mode, and for normal distribution mean is the best measure of central tendency. For normal distribution curve, mean is the best measure for central tendency. Mean is the best measure for central tendency. For non-normal distribution curve, okay, when the like normal distribution curve, mean is equals to median equals to mode. For normal distribution, mean is the best method measure of central tendency. Okay, so तिनटै normal छ भने mean भनेको त हाम्रो के हो, sum of the value को sum हो, त्यही भएर त्यो चाहिँ हाम्रो एउटै normal हुन्छ. For non-normal distribution curve, bimodal suggested to different population metabolic morphomerism such as fast versus slow accelerators, age of onset of Hodgkin lymphoma, suicide rate by age. So bimodal means suggests two different population. Example, metabolic polymorphism such as fast versus slow accelerators. Okay, age of onset of Hodgkin's lymphoma is to suicide rate by age. So when we have the positive skew, so mean is greater than median is greater to more, asymmetry with longer tail on right. Okay, negative skew is the mode is greater than median is greater than mean. Okay, mean is the least, mode median चाहिँ जहिले बिचमा हुन्छ, मोड चाहिँ हाम्रो mean चाहिँ बढी भयो भने पोजिटिभ हुन्छ, तर हाम्रो मोड चाहिँ बढी भयो भने चाहिँ नेगेटिभ हुन्छ. Okay, so the next thing is the hypothesis. Okay, so null hypothesis is simply hypothesis of no difference or relationship. There is no association between the disease and the risk factor in a population. Hypothesis of no difference or relationship, and there is no association between the disease and the risk factor in a population. भनेको null hypothesis भनेको के छ भने कुनै पनि एसोसिएसन छैन डिजिज र रिस्क फ्याक्टरमा, त्यसलाई चाहिँ हामीले null hypothesis भन्छ. तर अल्टरनेटिभ hypothesis of some difference or relationship, there is some association between the disease and the risk factor in a population. भनेको null hypothesis भनेको दुईटाको बिचमा रिलेसनशिप, अल्टरनेटिभ हाइपोथेसिस भनेको केही रिलेसनशिप छ. P value means the probability of obtaining test results at least as extreme as those observed during the test, assuming the H naught is correct. Okay, so the probability of obtaining the test results, P value means the probability of obtaining the test results at least as extreme as those observed during the test. So we have the correct results. So stating that there is a defect or difference when one exists. Okay, and stating that there is no effect or difference when none exist. Okay, so outcome of a statistical hypothesis testing is correct results means stating that there is an effect or difference when one exists, and stating that there is no difference, no effect or difference when none exist. So this is correct study. Okay, so reality of okay. So type 1 error means stating that there is a effect or difference when none exist. Okay, so that is type 1 error. So also called false positive error. So falsely positive देखियो कि difference था है ना, like first time boy cries wolf, the town believes that there is a wolf, but there is not. Okay, you never prove h1, but you can reject the h0 as early very unlikely. So alpha is the probability of making a type 1 error. So usually 0.05 is chosen. If p is less than alpha, then assuming h0 is true, the probability of obtaining the test result would be less than the probability of making a type 1 error. Okay, so statistical significance, type 1 error is statistical significance is not equal to clinical significance. So type 2 error is stating that there is not an effect or difference when one exists. Okay, h0 is not rejected here. So when it is false, fact false. So beta is the probability of making type 2 error. So beta is related to statistical power 1 minus beta, which is the probability of rejecting null hypothesis when it is false. So power means which is the probability of rejecting the null hypothesis when it is false. So increase power and decrease beta by increasing the sample size, increase expected effect size, and increase precision of measurement. So how can you increase the power like I said, increase sample size, increase expected effect size, and increase precise of measurement. So next is that we have having the confidence interval. So range of value with which true means of the population is expected to fall with a specified probability. So confidence interval equals to 1 minus alpha. Confidence 95% interval corresponds to 0.05. Okay, so confidence interval for mean is equals to mean plus minus standard deviation error into standard deviation. So for 95% confidence interval, z is equals to 1.96. For 99% confidence interval, z is equals to 2.58. h0 is rejected and results are significant when 95% confidence interval for mean difference excludes 0, 95% confidence interval or RR includes 1, or confidence between two groups do not overlap. h0 is accepted when confidence interval for mean includes 0, confidence interval for RR or OR includes 1, or confidence between two groups do overlap. So in this case, we reject the null hypothesis is accepted, null hypothesis is rejected, like we want to reject the null hypothesis. Okay, and results are significant. That's why the null results are significant. So भनेको हामीले जुन भ्यालुहरू निकालिरहेको छौँ हैन, त्यो सिग्निफिकेन्ट छ, त्यो भनेको हामीले नल हाइपोथेसिसलाई रिजेक्ट गरिरहेको छौँ. सो मेटा एनालाइसिस द मेथड स्टार्टिङ एनालाइसिस द पुल summary data mean हैन from multiple studies or a group of precise estimate of the size of effect, also estimate heterogeneity of effect size between studies, improves power, strength of evidence and genericity, external validity of the study, limited by quality of individual studies and bias in a selected population. So t-test means 6 difference between means of two groups, like comparing the mean blood pressure between men and women. ANOVA means 6 difference between the mean of 3 or more groups, that is comparing the mean blood pressure between the members of 3 different ethnic groups. We have Fisher extract test, that is the check the difference between the two percentage or proportion of categorical nominal outcome used instead of chi-square test with small population, compares the percentage of 20 men and 20 women with hypertension. So we have the chi-square test, which is a categorical outcome, check difference between two or more percentage or proportion of categorical outcome, not mean values. So example, compare the proportion of member of 3 age group who have essential hypertension. Okay, so variable to be compared, that is numerical two group. If you compare the variable between two group, we do t-test greater than 3 mean को बेलामा कुरा गर्ने. अब क्याटेगोरिकल भन्यो भने चाहिँ स्मल स्याम्पल साइजमा फिस एक्सट्र्याक्ट टेस्ट, वेयर लार्ज चाहिँ हामीले त्यो अर्को भन्यो. अब हामीले अर्को कुरा थाहा पाउनु पर्यो, मेजर अफ द लिनियर कोरिलेसन बिट्विन द टू भेरिएबल आर इज अलवेज बिट्विन -1 and +1. So closer the absolute value for r is equal to 1, the stronger the linear relation between the two variables. Variation in how much the measured value differs from the average value in the data set. Positive r is positive correlation, and there is one variable increases, the other variable increases. And negative r value means negative correlation, as one variable increases, the other variable decreases. So coefficient of determination equals to r square. So stronger correlation means it has to go to like down. Okay, so they are nearby, so it is like minus 0.4 coming downward. So minus 0.4 means it is quite going far, and r equals to 0, it's totally far. So when it is positive, so it has both has to be right, so the curve would be like to going to the right side. Okay, that's weak correlation, and r is equals to, so the correlation is between minus 0.8 to plus 0.8. So this was all about the biostat. So now we'll be talking about the communication. So in communication means introduce yourself and address the patients by preferred name. Okay, patient-centered interview techniques. So introduction. So introduce yourself and address the patient by preferred name. Sit eye level near patient. Now agenda setting. Identify concern. Set goals by developing joint agenda between physician and the patient. Reflection. Actively listen and synthesize information offered by the patient, partly with respect to primary concern. Now validation, that is legitimacy or affirm the patient's perspective. Now recapitulation, summarize what the patient has said so far to ensure correct interpretation. And facilitation means encourage the patient to speak freely without guiding response or leading question. Allow participants patients to ask questions through outcomes. So how to have an interview with the patient is introduce yourself and address the patient by preferred name. Identify concern and set goals by developing joint agenda between physician and the patient. Actively listen and synthesize information offered by the patient, partly with respect to particular concern. Legitimacy or affirm the patient's perspective. So after he says like this, why do you think like this is happening to you? Summarize what the patient has said so far to ensure correct interpretation, and encourage the patient to speak freely without guiding response or leading questions. Allow patients to ask questions through the encounters. So next we have the expressing empathy. So that is with the mnemonic PEARLS, PEARLS. So that is P for partnership, E for empathy, A for apology, R for respect, L for legitimacy, and S for support. So very high yield expressing empathy. So PEARLS is the mnemonic. So first, partnership. So reassure the patient that you will work together through difficult times and offer appropriate resource. Okay. Partnership means reassure the patient that you will work together through difficult times and offer appropriate resource. Empathy. Pilsko is empathy. Acknowledge the emotion, dispatch, and demonstrated understanding of why the patient is feeling the way that way. So first was like reassure the patient that तपाईँ र patient तपाईँको difficult time मा doctors छु. Next is acknowledge the emotion displayed and demonstrated understanding of why the patient is feeling that way. तपाईँ किन यसरी feel गरिराख्नु भएको छ. Now apology. Take after giving empathy, always take apology. That take personal responsibility when appropriate or often condolence for the patient's situation. Means after empathy, we always need to do what? Apology. Pills. E for apology. Okay. So take personal responsibility when appropriate or often condolence for the patient's situation. Next is respect. Comment the patients for coming to discuss a problem, push him through challenge circumstances, keep a positive attitude or other constructive behavior. Next is legitimacy. Assure the patients that emotional response are understandable or common. Support. Offer to help patient through difficult times. Support. So partnership, empathy, apology, respect, legitimacy, and support. PLC is partnership, empathy, apology, respect, legitimacy, and support. So it is, once again I'll say, PLC is empathy. So first we need to reassure the patient that you will work together through difficult time, often appropriate resource, and will acknowledge the emotions dispatched and demonstrate understanding of why the patient is feeling that way. Like suppose first the patient is feeling to die. Okay, let's take an example. So reassure that the patients will, I'm there to help you. Okay, so that is reassure the patients that you will work together through difficult times and offer appropriate situation. So now why the patient is thinking to suicide, you need to do empathy. Acknowledge the emotion dispatched and demonstrate understanding why the patient is feeling like to suicide. Now next is apology. Take personal responsibility when appropriate or often condolence for the patient situation. So first now we need to do what is take personal responsibility when appropriate or offer condolence for the patient's situation. Means, I'm so sorry that you like you are feeling like to suicide. Okay, पहिला तपाईँ किन सुसाइड गर्न खोजिराख्नु भएको छ हैन, त्यो कुरा बुझ्ने। र म एकदम सरी छु, त एकदम नर्मल फिल भइरहेछ कि तपाईँलाई यस्तो फिल भइरहेको छ, द्याट इज एपोलोजी। नाउ वी हेभ टु रेस्पेक्ट। आफ्टर डुइङ PEA we need to do RLS. Okay, so respect. So commend the patients for upcoming in to discuss a problem, pushes him through challenges, and keep positive attitude. Okay, we have to respect and make him to positive attitude. Commend the patients for upcoming in to process for pushing through challenges, circumstances, and keep a positive attitude or other circumstances behavior. Next is legitimacy. Assure the patient's emotional response are understandable or common. Means भनेको जब उसलाई तिमीले पोजिटिभ एटिट्युडले भन्यो भने उसलाई अब नेक्स्ट भन्यो भने यो यस्तो धेरै मान्छेहरू छन् जसलाई यस्तो फिलिङ हुन्छ। एजुर द पेसेन्ट्स इमोसनल रेस्पोन्स अन्डरस्ट्यान्डेबल अर कमन, अफर टु हेल्प द पेसेन्ट्स थ्रु आउट डिफिकल्ट टाइम्स सपोर्ट। So once again, reassure the patients that you will work together through difficult times and offer appropriate resource. Acknowledge the emotional distress and demonstrate understanding why the patient is feeling that way. Take responsibility when appropriate and offer condolence for the patient's situation. Commend the patients for upcoming in to discuss the problem, pushing through the challenge circumstances, and keeping a positive attitude or other constructive behaviors. Assure the patient that the emotional response are understandable and common, and offer to help the patients through difficult times. So next is delivering a bad news. So it's spike protocol. So setting, perspective, invitation, knowledge, emotion, and strategy. Very, very, very high yield topic. So first, spike means setting. Offer in advance for the patients to bring support, eliminates distraction and ensure privacy, and sit down with the patient's stop. Now perception. Determine the patient understanding and expectation of the situation. Invitation. Obtain the patient's permission to disclose the news. What level of detail is desired. Okay, then knowledge. Share the information in small pieces with medical jargons, allowing time to process, access the patient's understanding. Emotion. Acknowledge the patient's emotion and provide opportunity to express them. Listen and offer empathetic response. Now next is strategies. If the patient feels ready, discuss treatment option and goals of care, and offers an agent for the next appointment. So very, very high yield this spike protocol. Spike for setting for SPI and KES. Okay, so similarly in the empathy was PEA, RLS, delivering bad news is spikes. So setting, perception, invitation, SPI, KES, knowledge, emotions, and strategy. So spike is first, once again I'll repeat it, offer in advance for the patients to bring support, eliminate distraction, ensure privacy, and sit down with the patients to talk. Means simply support the patient and like a chair ma basaउने. Determine the patient's understanding and expectation of the situation. Means suppose cancer लागेको छ भने पहिले क्यान्सर लागेको मान्छेलाई त्यहाँ आफ्नो एउटा चेयर रुममा बसाउने. Think, imagine that. Now determines the patient on what you understand by like having gastric cancer. Okay, understand the expectation. तपाईँलाई के एक्सपेक्ट अन्डरस्ट्यान्डिङ छ र के एक्सपेक्ट गर्नुभएको छ तपाईँको यो ग्यास्ट्रिक क्यान्सरको. Obtain the patient's permission to disclose the news what level of detail is desired. Means अब यसको बारेमा तपाईँलाई कतिसम्म बुझ्न मन लागेको छ यो क्यान्सरको बारेमा हैन, ग्यास्ट्रिक क्यान्सरको बारेमा. Share the information in small piece. Now ठिकै छ, अलिअलि भन्नु सुन्नुहोस् न. Small piece with medical jargons, allowing time to process, access the patient's understanding. बुझिरहेछ कि छैन भन्ने कुरा उसलाई बिस्तारै बिस्तारै स्मल पिसमा भन्ने. नाउ अब ऊ हुन्छ यस्तो थाहा भएपछि acknowledge the patient's emotions, provide opportunity to express them, listen and offer empathic response. यो पेसेन्टले भन्छ किन भयो मसँग यो त्यो हैन, उनीहरूको एम्प्याथी सुन्ने. नाउ if the patient feels ready, discuss treatment. अब ऊ रुन थाल्यो हैन, अब यसको हामीसँग if the patient feels ready, discuss treatment option and goals of care, offer an agenda for the next appointment. Okay, so now the next is gender and sexuality inclusive history taken. Avoid making assumptions about sexual orientation, gender identity, and gender expression and behavior. Okay, a patient who identifies a heterosexual may engage in same sexual activity. Under gender neutral terms refers to patient partners rather than assuming that spouse gender. Okay, a patient's sex design at birth and gender identity they may differ. Consider the so gender, sexuality, inclusive history taking. Avoid making assumptions about sexual orientation, gender identity, Gender expression and behavior. A patient who identifies the heterosexual may engage in same-sex sexual activity. Use gender-neutral terms. Refer to patient's partner rather than assuming the spouse gender. A patient sex assigned at birth and gender identify may differ. Consider starting what pronouns you use when you introduce yourself. I am Dr. Smith and I use uh, he, she pronouns. And asking the patient how would like to be addressed. Reassure them about their confidentiality of the appointment and be sensitive to the fact that patient may not open about their sexual orientation or gender identity to others in their life. Do not bring up gender or sexuality if it is not relevant to the visit. Gender non-forming patients seek care for handlessness. So, trauma-informed communication. Patients with the history of traumatic experience should receive through behavioral health screening, regular access mode, substance use, social support, and suicide risk. Focus assessment on trauma-related symptoms that interferes with the social and occupational function. Do not ask invasive questions requiring the patients to describe trauma in detail. Before the physical examination, reassure patients that they may signal to end it immediately if they experience too much physical or emotional discomfort. Offer the patients of additional staff for support. So, patients with history of traumatic experience should receive through behavioral health screening, regular access mode, substance use, social support, and suicide risk. So the next is motivational interview. Okay. So counseling technique to facilitate behavior modification by helping patient resolves the mixed feeling about change. Used for many conditions, nicotine dependence, obesity, helpful when patient has some desire to change, but it does not require that the patient be committed to making the change. May involve asking patients to examine how their behavior interferes with their life or why they might want to change. As your behaviors, food access, untreated traumas that may make behavior change difficult. Access a patient's readiness for change is also important for understanding physical sustained goals. So goals should be smart to make a motivation. So it should be specific, measurable, achievable, relevant, and time bound. Smart goals. That is specific, measurable, achievable, relevant, and time bound. So the goals should be like specific, measurable, achievable, relevant, and time bound. Okay, so communication with parents with disability. Use person first language, which refer to a person with disability rather than a disabled person. Communication patient with disabilities. Use person first language, which refer to persons with a disability rather than a disabled person. Consider asking patient why terms they use to describe. Under most circumstances, talk direct to the patient. Do not assume that the non-verbal patient do not understand. Accompany care give and can add information to any discussion as needed. As if assistance is desired, rather than assuming that patients cannot do something alone. Most people, includes people with disabilities, value their independence. For patients with speech difficulties, provide extra time for the interview. If the speech is difficult to understand, consider asking them to write down a few words or ask them to rephrase their sentence. Repeat what they said to ensure your understand is correct. For patients with cognitive impairment, use concrete, specific language. Ask direct, ask simple, direct question. Eliminate background noise and distraction. Do not assume that the patient can read. Adjust to how the patient understand best. So, ask patients who are deaf or hard to hearing their preferred mode of communication. Use light touch or waving to get their attention. For patients who prefer to speak and lip read, eliminate background noise. Face the patient and do not change your mood of speaking. As with the other part of the medical history, do not bring up the disability if it is not related to this. A patient in a wheelchair with a ear infection. Do not skip relevant part of physical examination even if the disabilities make the exam challenging. Okay, so use the interpreter. With visit with a patient who speaks little English should utilize a professional trained medical interpreter unless the physician is also fluent in the patient's preferred language. Interpretation service may be provided in person by telephone or a video call. If the patient prefers to utilize a family member, this should be recorded in a chart. Do not assume that a patient is poor English speaker because of the name, skin tone, or accent. Ask the patient what language is preferred. The physician should make eye contact with the patient and speak to them normally without the use of the third person statement such as tell him. Physicians should make eye contact with the patient and speak to them normally without using our third person statement such as tell him. Allow time for the interviewer and ask a question at a time. For in-person speak language interpretation, the interpreter should ideally be next to or slightly behind the patient. For a sign language interpretation, the interpreter should be next to or slightly behind the physician. So we have these certain conditions like patient is not adherence, means not determined. So in that consider determine whether there are financial, logistic or other obstacles behind preventing the patient's adherence. Do not coerce the patient into adherence or refer the patient to another physician. Patient desire an unnecessary procedure. Attempt to understand why the patient wants that procedure and address the underlying concern. Do not refuse to see the patient or prefer another physician. Avoid performing unnecessary procedure. Patient has difficult taking medicine. Determine what factors are involved in patient's difficulty. If comprehension on memories are issue, use techniques such as providing a written statement, using a teach-back method, or simply treatment regimen. Family members ask for information about the patient's prognosis. Avoid discussing issue with the relatives without the patient's permission. The patient's family member asks you not to disclose the result of a test if the prognosis is poor because the patient will be unable to handle it. Explore why the family members believe this would be detrimental, including possible causal factors. Explain that if the patient would like to know the information concerning care, it will not be withheld. However, if you believe that the patient might seriously harm self or other if informed, you will involve therapeutic privilege and withhold the information. A 17-year-old is pregnant and requests an abortion. Many states require abortional notification or consent for minors for an abortion unless there is specific medical risk associated with the pregnancy. A physician should not sway the patient's decision for or against the elective abortion, regardless of the patient's age or fetal condition. Discuss options for determining terminating the pregnancy and refer abortion care if needed. A 15-year-old is pregnant and wants to raise the child. Her parents wants to tell her to give the child abortion. The patients retain the right to make a decision regarding her child even if the parents disagree. Patient information to the teenage about the practical aspects of caring for a baby. Discuss options for terminating the pregnancy if required. Encourage discussion between the teenage and her parents to reach the best decision. A terminally ill patient requests physician assist dying. Terminally ill patient requests physician assist dying. The overwhelming majority of the state prohibits most forms of the physician-assisted dying. Physician may, however, prescribe medically appropriate analgesic even if they potentially shortens the patient's life. Patient is suicidal. Assess the seriousness of the threat. If the patient is actively suicidal with a plan, suggest remaining in the hospital voluntary. Patient may be hospitalized involuntarily if needed. Patients state that you are attractive and ask you if you go to on a date. Use the chaperone if necessary. Romantic relation with the patients are nearby appropriate. It may be necessary to transition care to another physician. So, a woman has a mastectomy and says he now feels ugly. Find out why the patients feel this way. Do not offer falsely reasoned statement. You still look good. Patient is angry about the long time spent in the waiting room. Acknowledge the patient's anger, but do not take a patient's anger personally. Thank the patient for being patient and apologize for any inconvenience. Stay away from the efforts to explain the delay. Patient is upset with treatment received from another physician. Suggest the patient speak directly to the physician regarding the concern. If the problem is with a member of the office staff, tell the patient you will speak to the person. An invasive test is performed on the wrong patient. Regardless of the outcome, the physician is ethically obligated to inform the patient that mistake has been made. Okay, so now next is a patient requires treatment not covered by insurance. Discuss all treatment options with patient even if some are not covered by the insurance company. Inform patient of financial assistance program. A 7-year-old boy loses a sister to cancer and now feels responsible. At 5 to 7, child begins to understand that is permanent, that all functions are incompletely at death, and everything that is alive eventually dies. Provide a direct, concrete description of his sister's death. Avoid clinches and euphemism. Reassure the boy that he is not responsible. Identify the normal fear and feeling, encourage play and help coping behaviors, remembering here nor own. Patient is victim of intimate partner violence. Ask if the patient is safe and help devise an emergency plan if it is not. Educate patients on intimate partner violence resources. Do not necessarily press patients to leave a partner or disclose the incident to the authority. Patient wants to try alternative or holistic medicine. Explore any underlying reason with the patient is supportive, non-judgmental manner. Advise the patients to of no benefit and risk of treatment, including adverse effect, contraindication, and medical interaction. Physician colleague presents to work impaired. The present of a potential risk to patient safety. You have an ethical, usually a legal obligation to report impaired colleagues so that you can seize the patient's care and receive appropriate assistance in timely manner. Seek guidance in reporting as procedure and applicably law may be instituted as a step. Patient is officially determined to suffer branded. Patient's family insists on maintaining life support indefinitely because patient is still moving when touched. Gently explain to family that there is no chance of recovery and the brain death is equivalent to death. Movement is due to spinal arc reflex and is not voluntary. Bring case to appropriate ethics board committee, futility of care and withdrawal of life support. A pharmacist will company offer US sponsorship in exchange for advancing this new drug. Reject this offer. Generally declines gifts and sponsorship to avoid any conflict of interest. The AMCA Code of Ethics does not exception for gifts directly benefiting patients. Special fund for medical education of students, residents, fellows, grants, which speak are chosen by independent institute criteria, funds that distribute without attribution to sponsors. Patients requires a non-emergent procedure that is assigned to personal or religious belief. Provide accurate, unbiased information so a patient can make informed decision in a neutral, non-judgmental manner. Explain to the patient that you do not perform the procedure but offer to prefer another physician. Mother and 15-year-old daughter are responsible following a car accident and are bleeding internally. Father said do not transfuse because they are Jehovah's Witness. Transfuse daughter but do not transfuse mother. Emergent care may be refused by healthcare proxy for an adult, particularly when patient preferences are known to retain interment, but not for a minor based on the solely on faith. Or a dependent patient presents with injuries inconsistent with caretaker story. Documents detailed history and physician, if possible and appropriate. Interview the patients alone. Provide any necessary medical care. If suspicion remains, contact the appropriate agencies and authorities. Child or adult protective services for evaluation. Inform the caretaker of an or your obligation to report. Physician are required to by law to report any reasonable suspicion of abuse, neglect, or endangerment. A pediatrician recommends standard vaccination for a patient, but the child parents refuses. Address any concern that the parents have. Explain the risk and benefit of vaccination and why they are recommended. Do not administer routine vaccination without patient's consent. Thank you, ethics. Now we'll be talking about the ethics. So, core ethics principles are autonomy, obligation to respect parents as individuals, truth telling, confidentiality, to create conditions necessary for autonomous choice, informed consent, and to honor their preference in accepting or not accepting the medical care. So, autonomy means it is the patient's own right, obligation to respect patients as an individual. So, beneficence is physician has a special ethics duty to act in the patient's best interest. So, beneficence means patient's best interest. May conflicts with autonomy. Okay, autonomy means पेसेन्टको चोइसबाट फरक हुनसक्छ तर डक्टरले चाहिँ जे बेस्ट हुन्छ पेसेन्टलाई त्यही गर्नुपर्छ. इन्फर्म पेसेन्ट हेज अ राइट टु डिसाइड वाट इज बेस्ट फर सोसाइटी. Mandatory TB treatment, like the person has to take the mandatory TB treatment because that is the benefit for his interest and for his society. So patient interest supervedes. The patientले जे भन्छ तर त्यही मान्नुपर्छ. Okay, non-beneficence, do not harm, must be balanced between the beneficence. If the benefit outweighs the risk, patients can make an informed decision to proceed. Most surgeons and medications fall into this category. So next is justice, to treat person fairly and equally. This does not always imply equally trials. Okay, so to treat person fairly and equitably, this does not always imply equally trials. So decision making capacity, physician must determine whether the patient is psychologically and legally capable of making a particular healthcare decision. Note that the decision made with the capacity cannot be revoked, means taken back, simply if the patient later loses capacity. So, intellectual disabilities and mental illness are not exclusive criteria for informed decision making unless there is a condition present impairs their ability to make healthcare decisions. Capacity is determined by a physician for a specific healthcare related decision to refuse medical care. Competency is determined by a judge and usually refers to a more global category of making decision, legally unable to make any healthcare related decision. So component is of the decision making capacity is excessive capacity is of massive importance. So M for mental illness. So decision is not result of mental illness exacerbation. So person must not the whatever decision he is making, that decision is not result of mental illness. A for age. So patient is greater than 80 years of age or otherwise legally emancipated. Okay. So next is the person must have a mental status. Status should be good, like he should not be in delirium intoxications. Okay. So altered mental status should not be there. So next is S, stable over time. So decisions should remain stable over time. So next I, the patient is informed and understood. So patient understands what decision he is making. So next is V, that is value and goals. Decision is consistent with patient's values and goals. Okay, whatever decision he is giving, he is according to his values and goals. So expression, patients expresses preferences. So पेशेंट्स को जे प्रेफरेंस हुन्छ त्यही उसको डिसिजन मेकिङ क्यापेसिटीमा हुन्छ. So informed consent is a process, not just a document signature that requires. Informed consent means a process that requires disclosure, discussing of the relevant information using medical interpreter if needed, understanding the ability to understand, capacity and disclose and make the patients understand, and the capacity, ability to reason and make one's decision, distinct from competence and legal determination. Next is voluntary, freedom from force to do something. Okay, and manipulation means a patient should, in an informed consent means first what we need to do is to disclose everything to patient. He must understand, then from his capacity to make a decision by his voluntary work. So patient must have a comprehensive understanding of the diagnosis and the risk benefit of proposed treatment and alternative option, including no treatment. Patient must be informed of their right to revoke written consent at any time, even orally. So exception of informed consent is wipe. So when we don't need the informed consent. So waiver. Wipe is waiver. Patients state clearly in detail. Okay, voluntary cease to keep the right of informed consent means patient excessively replenishes the right of informed consent. So it's legally incompetent. Patients lack decision making capacity. Okay, during that condition, if the patient is mental illness is problem, we do not need informed consent. Okay, next is therapeutic privilege. Withholding information when disclosure would severely harm the patient of identifying into and decision making capacity. So, like if the patient is going to have something harm to himself, like he's going to suicide if we say something to him, so that we can use the therapeutic privilege at that time. So emergency situation, implied consent may apply. So emergency condition, we do not need the any thing. So therapeutic privilege means if the patient is going to have any harm, we do not need to name him. And if he is legally incompetent, so we do not inform him. And patient state clearly in detail that voluntary ceases to keep the right of informed consent. Okay. So consent for minors. So situation in which parental consent is usually not required, like the contraception, STDs, in which parent consent is not required for the treatment. A minor is generally any population less than 18 years old. Parent consent law in relations to health vary by state. In general, parents' consent should be obtained, but exceptionally exists for emergency treatment like blood transfusion, or if minor is legally emancipated, means free legally, married, left self-supporting, or in military. So basically, consent for minors is like less than 18 years old, parents consent चाहिन्छ. तर त्यहाँ exception छ, like in the emergency situation we do not need the parents, or if the म्यारिड सेल्फ सपोर्टिङ र मिलिट्रीमा छ भने 18 वर्षभन्दा मुनि भयो भने पनि प्यारेन्ट्सको चाहिँदैन। प्लस प्यारेन्ट्सको डिसिजन कतिखेर चाहिँदैन अरू माइनरको लागि भन्दाखेरि कन्ट्रासेप्सन, एसटिडिज, प्रिनेटल केयर, युजली नट एबोर्सन, ड्रग सब्सटेन्स युज डिसअर्डर ट्रिटमेन्ट एन्ड रक एन्ड रोल, द्याट इज इमर्जेन्सी एन्ड ट्रमा। Physicians should always encourage healthy minor guardian communication. Physicians should seek a minor assess agreement of someone's unable to legally consent even if the consent is not required. So advance directive instructions given by a patient in anticipation of need for a medical decision. Okay, so over advance directive, so derived of strength encapsulated patient's prior oral statement commonly used as a guide. Problem arise from variance in interpretation. If patient was informed directive was specific, patients make a choice and decision was repeated over time to multiple people, then oral directive is more valid. So oral directive means patient's prior oral statement commonly used as a guideline. So in written advance directive, describe specific healthcare intervention that patients regard accepting or rejecting during the treatment of a critically or ill treatment. A living will is an example. So living will is a written advance directive. So medical power of attorney. Orally भन्नु भनेको oral statement used as a guideline. Written भयो भने लेखेको बोलेको कुरा गाइडलाइन भयो, लेखेको कुरा गाइडलाइन भयो, त्यो चाहिँ उसको लिभिङ विल भयो। अब मेडिकल पावर अफ एटर्नी, पेसेन्ट डिजाइन्स एन्ड एजेन्ट। अब कसैलाई जस्तो मैले ओरली भन्नु, मैले उ गर्नु र मैले कसैलाई भनिदिनु भनेको मेडिकल पावर अफ एटर्नी। पेसेन्ट डिजाइन्स एन्ड एजेन्ट टु मेक medical decision in an event that the patient loses decision making capacity. Patients may also specific decision in clinical situation can be evoked by patients if decision making capacity is intact, more flexible than living will. Do not resuscitate order prohibits cardiopulmonary resuscitation. Patient may still consider other life measures like intubation, feeding tube. Only CPR ma CPR नगर्नु, यहाँ स्वाप प्रयोग गर्नुपर्छ। Surrogate decision maker. If a patient loses decision making capacity and has not prepared an advance directive, individual surrogates, people who know the decision patient must determine when the patients would have taken. Priority is first spouse, then their children, then their parents, then their sibling, and then the other relatives. So confidentiality. Confidentiality respects the patient's privacy and autonomy. If the patient is incapacitated or situation is emergent, disclosing the information to the family friends should be guided by professional judgment of patient's best interest. The patient may voluntarily waive the right to confidentiality insurance company request. General principle for exception to confidentiality is potential physical harm to self or other in serious condition. Alternative mean to warn or protect those in a risk is not possible. A step can be taken to prevent harm. So example of exception to patient's confidentiality is includes the physician good judgment saved the day. Patients with suicidal or homicidal ideation. So in what condition we need no confidentiality, that is saved. Okay, confidentiality लाई अब कन्फिडेन्ट भनेको लुकाएर नराख्ने निमोनी के हो भन्दाखेरि सेभ, लाइक वेन द पेसेन्ट इज ह्याभिङ सुसाइडल र होमिसाइडल आइडिएसन अर वेन द पेसेन्ट इज ह्याभिङ एब्युज चिल्ड्रेन एल्डरली अर प्रिजनर। ओके, कतिखेर हामीले सबैलाई भनिदिने जतिखेर पेसेन्टले चाहिँ सुसाइड गर्न खोज्छ होइन, होमिसाइड होला अथवा एब्युज गर्छ बच्चाहरूलाई, एल्डरलीलाई, प्रिजनर्सलाई। अनि victim for harm, V is saved ko, V is victim for harm. So duty to protect, state specific law sometimes allows physician to inform or somehow protect potentials. So SAV, now ED. So E is epilepsy. Patient with epilepsy and other impaired automobile drivers मा चाहिँ हामीले confidentiality लाई ब्रेक गर्नुपर्छ। मिन्स सबैलाई भनिदिनुपर्छ उसलाई एपिलेप्सी छ, उसलाई ड्राइभर नदिनु। रिपोर्टेड डिजिज लाइक एसटिडिज, अब सबैलाई कन्फिडेन्सियलिटी नराख्ने होइन, रिपोर्ट डिजिज, रिपोर्ट गर्ने डिजिजलाई एसटिडिज, हेपाटाइटिस अनि फुड लाइक एचआइभी, ओके, हेपाटाइटिस बी भाइरस होइन, फुड पोइजनिङहरू। फिजिसियन मे अल्सो हेभ अ ड्युटी टु वार्न पब्लिक अफिसर्स एन्ड विल notify people at risk. So dangerous communicable disease such as TB or Ebola may require involuntary treatment. Okay. So now we have the very important. This was all about the ethics. So now we'll be talking about the communication, okay, which is very very high yield. So before talking about the communication, we'll be talking shortly on the public health preventions. Sorry. So primary prevention means prevent disease before it occurs, like HPV vaccine. So secondary disease prevention means screening early for managing existing but asymptomatic disease like pap smear or cervical cancer. Tertiary means to reduce the complication from disease that is ongoing and has long effects like chemotherapy. Quaternary disease means quit, avoid unnecessary medical interventions to minimize the incidental harm. Imaging studies optimizing medicine to reduce the pharmacy. So major medical insurance plan, we have the insurance plans are like exclusive. So the exclusive provider major medical insurance plans includes the exclusive provider organizer, restricted to limited panel, except emergencies, no referral required. So next we have the health maintenance organization, restricted to limited panels. Okay, so exclusive means restricted to limited panel, except emergencies. Okay, so health maintenance organization is also restricted to limited panels. Most affordable health maintenance organization requires referral from primary care providers. So point of service means patient can see providers outside network. So high copay and deductible from out of the service. Okay, and primary requires for primary care providers. Preferred provider organization, patient can see providers outside his network also. So higher copay and deductible for all service, no referral required. So what is the difference between the point of service and the preferred provider organization? Preferred provider organization is point of service requires the referral, whereas the preferred provider organization do not require no referral. So accountable care organization means provider voluntary enrolls. So payment is Medicare, and specialist care is specialist voluntary enrolls. So accountable care means specialist is enroll. Okay, now next we have the healthcare payment models. So we have bundled payment, that is healthcare organization receives a set amount per service regardless of ultimate cost to be divided among all the providers and facilities involved. So bundle में दिने पैसा. Next is capacitation, means physician receives a set amount per patient. Capacity भनेको उसको capacity per patient कति दिने and assigned to them per period of time regardless of how much the patient used the healthcare system used by some HMO. So next we have the discounted free for service, means insurer or the patient pays for each individual service at a discounted rate predetermined by provider and payers. Okay, free for service means insurer or patient pays for such each individual service. Free for service means insurer or patient pays for each individual services. Next is global payment. Okay, insurer or a patient pays for all the expenses associated with the single incident of care with a single payment, most commonly used during the elective surgeries, as it covers the cost of surgery as well as the necessary pre and post operative visits. So next is the Medicare and the Medicaid. So Medicare and the Medicaid is federal social health care program that organizes from amendment to the Social Act. Okay, Medicare is available to patients greater than 65 years old and less than 65 with certain disabilities and those with the end-stage renal disease. So Medicare and Medicaid, federal social health program that organizes from amendment to Social Security Act. So Medicare मा लास्टमा ई छ, त्यही भएर चाहिँ एल्डरलीलाई यो मेडिकल एड इज डी फर डिसएडभान्टेज्ड. Okay, so medical care is care E for elderly, so greater than 65 and less than 65 for disabilities and those with end-stage renal disease. Whereas Medicaid is joint federal and state health assistance of people with limited income. So elderly means disadvantage, limited income मान्छेलाई दिनु पर्यो. So Medicare को चारवटा पार्ट हुन्छ. ओके, जुन चाहिँ हामीले एल्डरलीहरूलाई दिन्छौँ, द्याट इज एबिसिडी. सो बुढापाकालाई दिने भनेको एबिसिडी हो. ए भनेको चाहिँ हस्पिटल एडमिसन इन्क्लुडिङ हस्पिटल केयर इन्क्लुडिङ नर्सिङ केयर. बी फर बेसिक मेडिकल बिल्स, फिजिशियन फिज एन्ड डायग्नोस्टिक टेस्टिङ. सी फर कम्बोज डिलिभर्ड बाई एप्रुभड ए प्लस बी इक्वल्स टु सी कम्बो. सो हस्पिटल एडमिसन दिनु होइन र हस्पिटल केयर दिनु होइन. अनि फिजिशियन भनेको बीमा पर्छ, त्यति याद राख. फिजिशियन जुन डायग्नोस्टिक टेस्ट लेख्छ त्यो चाहिँ बीमा पर्यो, बाँकी सबै हस्पिटल रिलेटेड चाहिँ सबै ए पर्यो. सी भनेको चाहिँ डिलिभर्ड एप्रोप्रिएट प्राइभेट कम्पनीज, डिलिभर्ड बाई एप्रोप्रिएट प्राइभेट कम्पनीजहरूले दिन्छ. डी भनेको ड्रगको दबाईहरूको पनि मेडिकेयर उसलाई दिनु पर्यो. सो हस्पिटल केयर, मेडिकल केयर फोर्स्ड अन प्रोभाइडिङ कम्फर्ट एन्ड पेलेटिभ इन्स्टेड अफ डेफिनेटिभ क्योर, available to patient on Medicare or Medicaid as the most private insurance companies whose life expectancy is less than 6 months. So duration end of life care is a priority is given to improving the patient's comfort and relieving pain, often includes the opioid, sedative, or anxiolytic medication. Facilitation confront is prioritized over potential side effect, respiratory depression. This prioritization of positive effect over negative effect is called principle of double effect. So, facilitating comfort is prioritized over potential side effect, respiratory depression. This prioritization of positive effect over negative effect is called principle of double effect. So, common cause of death in US by age is less than 1 year. It is the congenital malformation. 1 to 14 years, the most common cause of death in US is unintentional injury. So that occurs from 1 year to 34 years of age. There is unintentional injury. So 35 to no 1 to 44. It is the common cause of death is in US is 1 to 44 years of age, unintentional injury. So between this period, in less than 1 year, we have congenital malformation, preterm birth, and pregnancy complication. But when you talk about the 1 to 44 years, that is unintentional in death. In 15 to 34, there is a suicide or homicide. But leaving the 15 to 34 years, the common cause of death from 1 to 44 is cancer and the heart diseases. Okay, congenital malformation in 1 to 14 years. So 45 to 64 years, the risk of cancer increases. 65 plus is heart disease. Similarly, in 45 to 64 years, because cancer, heart disease, or intestinal injury, whereas 65 plus is heart disease, cancer, and chronic respiratory diseases. So similarly, we'll be talking about the safety culture. So that is organizing environment in which everyone can freely brings up safety concern without hearing or penalty. Facilitate error identification, prevent reporting system, collect data on error for internal and external monitoring. So human factor design, that is forcing function, then those prevent undesirable actions. Connecting feeding syringe to IV syringe, okay, are the most effective. Standardization is improving the process reliability, clinical pathway guideline and checklist. Simplification means reduce wasteful activities, consolidating electronic medical system records. Simplification. Deficient design hinders overflow and leads to staff workaround and may that bypass safety features. Patient's ID barcode affixated to computer due to unreadable waste time. PDSM, process improvement model to test change in real clinical setting. Impact on patients is plan, define problem and solution. Plan, then do. Test new process, study, measure and analyze data, and act. Integrate new process into work. So plan, do, study, act. So quality measurement, there is structural, process, outcome, and balancing. So in structure quality measurement, we have the physical equipment, resource and facilities. So number of diabetic educators. So process, we have performance of system as planned. So percentage of patients with diabetes with HbA1c are measured in the 6 months. So structure was like number of diabetic educators. Process is the HbA1c measured in 6 months. So outcome, impacts on patient is average HbA1c of patient with diabetics. So balancing is impact on the system is incidence of hypoglycemia among patient who tried intervention to lower the HbA1c. So switch model is focus on the system condition rather than an individual error. The risk of a threat become reliability is mitigated by different layers and type of defense. Patient's harm can occur despite multiple safeguards when holes in the cheese lines. So next is type of medical error. May improve patient's identification, diagnosing, monitoring, nosocomial infection, medication procedure, device, documents, hand draw. Medical error should be disclosed to patient. Implementation of immediate outcome. So we have the active error that is occurs at the level of front liner operator. Okay, IV pump dose program. Latent error. We have the accident waiting to happen, like occurs in process in indirect from operator but impacts patient's care. Different types of IV pump used with same hospital. That is the latent, means hidden error. Okay, active error means wrong IV pump dose programmed. So a never event is adverse event that is identifiable, serious, and usually preventable. Scarf written surgery, that is never event. Major error that should never occur. And near miss. See, unplanned event that does not results in harm but can be potential to do so. Pharmacists recognize the medical interaction and cancels the order. Narrow prevention of harm than exposed danger. So burnout and fatigue. Burnout means prolonged excessive stress, cynicism, detachment, decreased motivation, interest, sense of failure, harmlessness, decreased immunity, medical error due to reduced professional efficacy. Whereas we have the fatigue, which is sleep deprivation, decreased energy and motivation, cognitive impairment, medical error due to the compromised intellectual function. So medical error analysis, root cause analysis, retrospective approach applied after failure event to prevent recurrence. Use records and participants interview to identify all the underlying problems, process, people, environment, equipments, materials, management that leads to an error. Now we have the failure model and effect analysis, forward looking approach applied before process implementation to prevent failure occurrence. Use inductive reasoning to identify all the way a process might failure and prioritize them by their ability to occurrence and impact on the patients. Okay, this was